Let us read about acute respiratory distress syndrome ARDS. Acute respiratory distress syndrome ARDS, previously called adult respiratory distress syndrome, is a clinical syndrome characterized by a sudden and progressive pulmonary edema, increasing bilateral infiltrates on chest X-ray, hypoxemia refractory to oxygen supplementation, and reduced lung compliance. These signs occur in the absence of left-sided heart failure. Patients with ARDS usually require mechanical ventilation with a higher than normal airway pressure. A wide range of factors are associated with the development of ARDS, that is aspiration, drug ingestion, hematologic disorders, prolonged inhalation of concentration of oxygen, localized infection, metabolic disorders, trauma, fat or air embolism, systemic sepsis, including direct injury to the lungs, example smoke inhalation, or indirect insult to the lungs, examples shock. ARDS has been associated with the mortality rate of as high as 50% to 60%. The major cause of death in ARDS is non-pulmonary multiple system organ failure, often with sepsis. Pathophysiology. ARDS occurs as a result of an inflammatory trigger that initiates the release of cellular and chemical mediators, causing injury to the alveolar capillary membrane. This results in leakage of fluid into the alveolar interstitial spaces and alterations in the capillary bed. Severe ventilation perfusion mismatching occurs in ARDS. Alveoli collapse because of the inflammatory infiltrate, blood fluid and surfactant dysfunction. Small airways are narrowed because of interstitial fluid and bronchial obstruction. The lung compliance becomes markedly decreased. That is called stiff lungs. And the result is the characteristic decrease in functional residual capacity and severe hypoxemia. The blood returning to the lung for gas exchange is pumped through the non-ventilated, non-functioning areas of the lung, causing a shunt to develop. This means the blood is interfacing with non-functioning alveoli and gas exchange is markedly impaired, resulting in severe refractory hypoxemia. Clinical manifestations. Clinically, the acute phase of ARDS is marked by a rapid onset of severe dyspnea that usually occurs 12 to 48 hours after the initiating event. A characteristic feature is arterial hypoxemia that does not respond to supplemental oxygen. On chest X-ray, the findings are similar to those seen with cardiogenic pulmonary edema and present as bilateral infiltrates that quickly worsen. The acute lung injury then progressed to fibrosing alveolitis with persistent severe hypoxemia. The patient also has increased alveolar dead space, ventilation to alveoli but poor perfusion, and decreased pulmonary compliance, stiff lungs, which are difficult to ventilate. Clinically, a patient is thought to be in a recovery phase if the hypoxemia gradually resolves and the chest X-ray improves and the lungs becomes more compliant. Assessment and diagnostic findings. Intercostal retractions and crackles as the fluid begins to leak into the alveolar interstitial space are evident on physical examination. A diagnosis of ARDS may be made based on the following criteria: a history of systemic and pulmonary risk factors, acute onset of respiratory distress, bilateral pulmonary infiltrates, clinical absence of left-sided heart failure, and a ratio of partial pressure of oxygen of arterial blood to fraction of inspired oxygen less than 200 mm of mercury. That is severe refractory hypoxemia. Medical management. The primary focus in the management of ARDS includes identification and treatment of the underlying condition. Aggressive supportive care must be provided to compensate for the severe respiratory dysfunction. This supportive therapy almost always includes intubation and mechanical ventilation. In addition, circulatory support, adequate fluid volume, and nutritional support are important. Supplemental oxygen is used as the patient begins the initial spiral of hypoxemia. As the hypoxemia progresses, intubation and mechanical ventilation are instituted. The concentration of oxygen and ventilator setting and modes are determined by the patient status. This is monitored by arterial blood gas analysis, pulse oximetry, and bedside pulmonary functions testing. Positive end expiratory pressure PEEP is the critical part of the treatment of ARDS. PEEP usually improves oxygenation, but it does not influence the natural history of the syndrome. Use of PEEP helps to increase functional residual capacity and reverse alveolar collapse by keeping the alveoli open, resulting in improved arterial oxygenation and a reduction in the severity of the ventilation perfusion imbalance. By using PEEP, a lower FiO2 may be required. The goal of the PaO2 greater than 60 mm of mercury or an oxygen saturation level greater than 90% at the lower possible FiO2. Hypovolemia must be carefully treated without causing further overload, and inotrope or vasopressor agents may be required. Pulmonary artery pressure catheters are used to monitor the patient's fluid status and the severe and progressive pulmonary hypertension sometimes observed in ARDS. Pharmacologic therapy. Pharmacologic treatments include human recombinant interleukin-1 receptor antagonist, neutrophil inhibitors, pulmonary specific vasodilators, surfactant replacement therapy, antisepsis agents, antioxidant therapy, and corticosteroids late in the course of ARDS. Nutritional therapy. Patients with ARDS require 35 to 45 kilocalorie per kg per day to meet caloric requirements. Enteral feeding is the first consideration. However, parenteral nutrition also may be required. Nursing management. General measures. The patient with ARDS is critically ill and requires close monitoring because of the condition could quickly change to the life-threatening situation. Oxygen administration, nebulizer therapy, chest physiotherapy, endotracheal intubation or tracheostomy, mechanical ventilation, suctioning and bronchoscopy. Positioning is important. The nurse should turn the patient frequently to improve ventilation and perfusion in the lungs and enhance the secretion drainage. Oxygenation in ARDS patient is sometimes improved in the prone position and may be used in the special circumstances. Studies to assess the benefits and problems of such positioning are still ongoing. The nurse should explain all procedures and provide care in a calm, reassuring manner. It is important to reduce patient's anxiety. Rest is essential to reduce oxygen consumption, thereby reducing oxygen needs. And ventilator considerations. If the patient is intubated and receiving mechanical ventilation with PEEP, several considerations must be addressed. PEEP, which causes increased end expiratory pressure, is an unnatural pattern of breathing and feels strange to the patient. The patient may be anxious and fight the ventilator. Nursing assessment is important to assess for problems with ventilation that may be causing the anxiety reaction. Tube blockage by kinking or retained secretions. Other acute respiratory problems, example pneumothorax, pain and a sudden drop in oxygen level, the patient level of dyspnea and or ventilator malfunction. In some cases, sedation may be required to to decrease the patient's oxygen consumption, allow the ventilator to provide full support of ventilation, and decrease the patient's anxiety. Possible sedatives are lorazepam, midazolam, haloperidol, propofol, and the short-acting barbiturates. If the PEEP level cannot be maintained despite of the sedatives, neuromuscular blocking agents such as Pavilon, Dracurium may be given to paralyze the patient. This allows the patient to be ventilated more easily. With paralysis, the patient appears unconscious, loses motor function, and cannot breathe, talk, or blink independently. However, the patient remains sensation and is awake and able to hear. The nurse must reassure the patient that the paralysis is a result of medication and temporary. Paralysis should be used for shortest possible time and never without adequate sedation. Use of paralytic agent has many dangers and side effects. The nurse must be sure the patient does not become disconnected from the ventilator because respiratory muscles are paralyzed and the patient will be apneic. Consequently, the nurse ensures the patient is closely monitored at all times. All ventilator and patient alarms should be on at all times. Eye care is important as well as because the patient cannot blink, increase the risk of corneal abrasions. Neuromuscular blockers predispose patients to the development of deep vein thrombus, muscle atrophy, and skin breakdown. Nursing assessment is essential to minimize the complications related to neuromuscular blockade. The patient may have discomfort or pain but cannot communicate these sensations. Analgesia is usually administered concurrently with neuromuscular blocking agents. The nurse must anticipate the patient's needs regarding pain and comfort. The nurse checks the patient's position to ensure it is comfortable and in normal alignment and talks to and not about the patient while in the patient's presence. In addition, it is important for the nurse to describe the purpose and effects of the paralytic agents to the family. This experience can be very frightening to family members if they are unaware and these agents have been administered. Thank you.